Welcome, everybody. We are just giving everybody a minute or two to finish joining us, and then we'll get started. All right, everybody, I'm going to get us started. Thanks again for everybody who has made it to today's opening session. Just going to put a slide up already. Let me do that before we get started. There we go. I hope you can all see that. If there's any problem, please let us know. Welcome, everybody. Before I get started, please note that interpretation is being provided in Spanish, French, Russian, and Arabic. If you want to use any of that, please click the language that you would like to hear on the interpretation tab. We're very glad to have you here for the first of the 8 sessions on this health talk series on nutrition as we prepare for the Nutrition for Growth Summit later this year. WHO and UNICEF are hosting this week-long series of webinars that focus on improving nutrition through a multi-systems approach. My name is Saul Guerrero, and I'll be serving as your moderator for this webinar today. In preparation of the summit, the Department of Nutrition and Food Safety of WHO and the UNICEF Nutrition section of the program group are hosting these series of virtual events focused on improving nutrition through a multi-systemic approach. This week's events will highlight key priorities and actions that countries are taking or are planning to take to deliver essential nutrition actions in the health systems and promote safe and healthy diets to ensure healthy and well-being for all. Today's session is focused on the early identification and treatment of child wasting, and the key objective is to introduce the ambitious and impactful country commitments that a number of different countries are making in the context of N4G. Before we get started, I'd like to let everybody know that this session is being recorded and will be shared on the Health Week website. Also, there will be a question and answer session at the end of it, so we encourage everybody to use the question tab, the Q&A tab that you have at the bottom of your screen as well to pose your questions. We'll be tracking those questions as we prepare for the Q&A. On that note, I'll just get us started today with a really brief introduction of the issue, and then I'll start handing it over to the government representatives that have kindly made themselves available today to share their experiences. Now, why are we here? The fundamental answer to that question is that as part of the Sustainable Development Goals, the world committed to reducing child wasting. Now, this includes a commitment to reducing child wasting by less than 5% by 2025, and to continue that positive reduction trend so that we get to a point where there's less than 3% of children suffering from wasting by 2030. Now, Now, since these targets were adopted, however, the proportion of children who are suffering from wasted has remained virtually unchanged. Last year's report showed that child wasting affects an estimated 6.7% of children under 5, which has remained largely unchanged since the 8% prevalence that we had as far back as the year 2000. If the current trends continue, the world is unlikely to meet these sustainable development government targets. But what we have seen, though, during that same period is great progress in other forms of undernutrition, including child stunting. And that gives us hope that with concerted action and by prioritizing this issue, we can see equally positive trends happening on wasting between now and 2030. Now, as that happens, there's also great news. There is great news in the sense that we have seen great progress in the last few years in the number of children who are able to access treatment for child wasting once it occurs. Going back to 2012, in the past 8 years, we have almost doubled the number of children who receive treatment from an estimated 2.6 million in 2012 to an estimated 5.4 million last year. So whilst we have been unable to make the progress that we need to make when it comes to preventing the condition from occurring, we have made remarkable progress in making sure that life-saving treatment remains available to everybody who needs it. Now, this success is partly the result of the expansion of treatment services and in particular community-based treatment models. During that same period, we have seen the introduction of the community-based management of acute malnutrition model around the world, and today around 70 countries implement this as their primary intervention. And that has been an integral part of how we have been able to see that rapid expansion in the number of children who access treatment. Central to that success, however, has been as well the growth or the rapidly growing numbers of children who are screened every year for child wasting. Last year alone, an estimated 138 million children were screened for wasting, which means that in addition to the 6 million or so that receive treatment, there's a great deal more who are being screened on a regular basis to check their condition and refer to treatment whenever needed. And that is an essential part of continuing this positive trend. Now, central to that strategy of screening has been the growth that we have seen in communities themselves screening. We like to often say that MUAC bands should become as commonplace and as widely found as thermometers are in other parts of the world. It's a low-cost tool that enables parents to make decisions about when to seek healthcare. And what we're seeing more and more with strategies like the family MUAC approach is a growing number of women and other caregivers around the world being empowered to make the determination of when their child is losing weight and is getting into a situation where treatment might become necessary. So what we're seeing and on the issue of child wasting is that progress is happening on making treatment more widely available and as close to universal as possible. So the big question is, what can we do to build on this momentum and accelerate efforts to prevent, detect, and treat child wasting? Well, the Global Action Plan on Child Wasting, which was launched by the UN Secretary General back in 2018, presents us with a unique opportunity to transform our approach to child wasting, not only because it represents the first coordinated effort to harmonize the global response to child wasting, but because it's quite specific about how one can go and do that. Arguably one of the most remarkable parts of the Global Action Plan on Child Wasting is that it provides 4 interim objectives that countries can focus on if they want to see the rate of child wasting decreasing. 1 is reducing the incidence of low birth weight. 2, improving child health. 3, improving infant and young child feeding. And 4th and last, improving treatment of children with wasting. But the plan also is quite specific about how we can do all of these things. For example, it very clearly identifies maternal nutrition as a key front if we are going to see improvements in birth weight and therefore reductions in the risk of being born already at risk of becoming wasted. Improving access to primary healthcare, water and sanitation services is another essential part of achieving that improvements in child health that we need. Improving breastfeeding practices and children's diets in the first years of life is also absolutely essential to ensure that children become protected or remain protected from wasting. And finally, strengthening health systems and integrating treatment into routine primary health services is essential to making treatment services available to all. This framework for action, when launched in 2019, rapidly became the framework through which countries around the world have begun to lay out their agendas for addressing wasting. And what we want to do today is spend most of our session discussing how some countries in particular have taken on this framework and begun shaping their roadmaps for action. Now, today is about showcasing these examples, but it's also about giving you an opportunity to understand sort of the process for making commitments, sort of the support that these countries are going to need from all of us in order to achieve these commitments, and to pose your questions around the process and what is coming out of these processes, so we can have an open and rich discussion about yes, the road to N4G and how we can support countries to continue to develop their strategies in addressing wasting. To get us started, I'm going to invite our first panelist from Pakistan, Dr. Khawaja Masood Ahmed, to tell us a little bit more about the experiences in Pakistan of identifying key actions to take for the prevention, detection, and treatment of child wasting. Over to you, Dr. Ahmed. Can you hear us?
Thank you. Thank you very much, Saul, for giving me this opportunity to present what we are doing in Pakistan in order to reduce the incidence and prevalence of wasting in the country. Next, please. This first slide shows trends of wasting for the last almost 50 plus years. As you can see that in 1965, the first survey was carried out in Pakistan and it showed 11% wasting. And since then, the number of wasted children and the rate of wasting has increased progressively. There is just one dip of 8.6, and it was not actually National Nutrition Survey. It was the micronutrient survey that was carried out during that period of time. And probably the sample size was less. Unfortunately, the increase in the prevalence or increase in the number of wasted children is rapid during the past couple of decades, and there are many reasons which we'll be discussing during the next slides. Next, please. This slide shows the national divide between the urban and rural population, as well as MAM and SAM cases. As you can see, out of 17.17% national wasting rate, 8% are SAM and 9.7% are MAM. The difference is not much due to the fact that the treatment services are not available in the country, and almost less than 10% children are being covered. So they rapidly convert to SAM when they are not treated. And if we see the urban-rural divide, you don't see a very appreciable difference. Even in urban settings, the prevalence or the percentage of wasting is 16.2, which is definitely above WHO threshold. And rural is pretty higher, 18.6. And again, in both the cases, you can see that though SAM percentage is less, but appreciably not so much that we can say that we are targeting children during the MAM phase. Next, please. We have at present 4 areas, 1 capital territory and 3 regions. And all the 3 regions and capital territory, they just make less than 10% of the population. But the difference in the territories as well as the provinces is very appreciable. Sindh province has the highest rate of GAM, which is 23.3%, and it is pretty high. And there has been some improvement during the past 7 to 8 years, and it has come down by 3 to 4%. But again, the level of food insecurity and poverty has played a havoc in this province, followed by KP, newly merged district. Previously, we called them FATA, federally administered tribal areas. And these regions, this territory has been the area most affected by different conflicts, specifically our bordering country, Afghanistan. Next, please. Now, what are the commitments? Pakistan is one of the pilot countries for GAP, and we have committed that we would be able to reduce uh, low birth weight prevalence from 22 to 15% in the next 4 years. We will be increasing the exclusive breastfeeding to 55%. And similarly, the idea or the plans are to increase the coverage of wasting treatment from less than 10% at present to more than 50% by the end of 2025. Similarly, child health improvement through UHC, we will like to take it to 65%, which is at present 47.1%. Next, please. These are some of the actions through which we think that we would be able to achieve those targets. First of all, wasting management has been made an integral part of all these stunting reduction strategies. And this was first carried out in Pakistan multi-sectoral nutrition strategy developed during 2018-19. And also all the nutrition programming now have wasting management as the integral part. And the large scale national nutrition program that we are going to launch very soon would be the first of this initiative in which the wasting management has been built in as an integral part. Pakistan has prepared operational roadmap 2021-2025 for the gap on child wasting, and prevention is the focused area with maternal and IYC, maternal nutrition and IYCF. And we, as I mentioned in the previous slide, we intend to improve the coverage of wasting management from less than 10% to more than 50%. National Nutrition Action Plan is being developed nowadays. This would have the costed provincial government implementation plans. Domestic financing and increase in human resource. The National Nutrition Program that I was talking about a while ago that we have developed and which we will be soon launching, the cost is about USD $2 billion for the next 5 years. And we aim to target 15 million women of reproductive age and around 10 million children under the age of 5 years. And this is the biggest domestic financing that has ever been utilized for nutrition programming in Pakistan. Next. We are also going to initiate the revision of CMAM guidelines as the guideline for management of wasting. Local production of RUSF and RUTF has been secured. Government of Pakistan even have exempted the duties and taxes on import of the raw material, thus reducing the cost of the local production of these two supplementary and therapeutic food. Multi-sectoral planning for wasting is as below. National and provincial level multi-sectoral strategies and plans are in place. We have established partnership with the social safety programs to enhance their technical capacity on nutrition sensitive food assistance programs. Nutritious and healthy food has been included in the food distribution in emergencies, and nowadays also we are again facing an emergency with the influx of refugees from Afghanistan. Social protection program both at the federal and provincial level have been linked with the other humanitarian and emergency relief programs to improve and scale up the nutrition interventions in those areas. Feeding in emergencies provides fortified supplementary and complementary food for PLWs and children 6 to 59 months of age, with the special focus, assistance of traditional cash transfers. Next, please. What we need from the partners and donors is the technical and financial support in scaling up of preventive approaches, especially the maternal nutrition. The interventions or the strategies leading for the maternal nutrition and IYCF. We would also appreciate support in research and evidence generation on local recipes for cost reduction in treatment. In spite of the fact that local production of RUSF and RUTF is in place in Pakistan, but still cost of treatment is very high, and we feel that this cost is one of the major challenge to increase the wasting treatment in Pakistan. And we would also support technical and financial assistance in program implementation to scale up the program to the uncovered areas in the country and also in accountability. Next. Thank you very much. That's all from Pakistan.
Thank you very much, Dr. Masood Ahmed. Very, very helpful and great to hear of the Pakistan experience. We're getting a few questions in the Q&A, but I think we'll save those for after the presentation from our colleagues in the Philippines, if that is okay with you, Dr. Ahmed. On that note, Dr. Hoke, can you hear us?
Yes, I can.
Hi, welcome, and thank you for joining us. I know it's getting late over there, so we appreciate you making the time to share with us the experiences from the Philippines. So on that note, directly over to you. I hope that you can share your slides with us.
Good morning or good evening, everyone, wherever you are in the world. Thank you very much to our colleagues from WHO and UNICEF for inviting us over to share, but more importantly, I guess to learn from all other country experiences and from your questions later on. Our presentation will center towards the country's efforts in early identification and treatment of wasting. And by no means we are saying that we are there already in terms of what we want to achieve. So much still needs to be done, and we do hope that these discussions will actually be able to help us clarify how else we can crystallize our local strategies. So in terms of just child wasting in the country, the prevalence of wasting in children under 5 years old for the last 3 national surveys conducted from 2015 to 2019 are as follows: 7.1%, 5.6%, and 5.8%. We do have a target of 3.7%, though, as part of our SDG goals in terms of the prevalence of malnutrition for children overall. We do also have the PPAN, or the Philippine Plan of Action for Nutrition, and within this sits our wasting specific strategy. So under the PPAN, we did have a lot of targets related to stunting, wasting, vitamin A deficiency, anemia, urinary iodine concentrations, etc. And then you'll see that the target from 2017 to 2022. So for wasting of under 5 and wasting for 6 to 10, you'll see that our targets are around 7.1% to reaching below 5%. So for both. In terms of addressing child wasting, we really started from a humanitarian and development context, and then slowly incorporating this into our broader health sector interventions. So the humanitarian and development context began when we did have our partners from Save the Children, Doctors Without Borders, and CFSI, Community and Family Service International, with UNICEF and WFP working on a program back in Mindanao in southern Philippines in conflict municipalities. So it started as a small program there, and then eventually, the learnings were actually incorporated into the national program, which is now called the PMAM, or the Philippine Integrated Management of Acute Malnutrition. So it's a specific public health strategy which we adopted way back in 2015 to address acute malnutrition. So the idea is not so much to package it as a vertical program, which is quite typical still until now, but really to make links with other interventions from WASH, which can be health sector specific, social welfare and protection, and agriculture, so that we can link the treatment towards a more sustainable pathway. In terms of just the main history and milestones of PMAM, So as mentioned, though, it started as a humanitarian response back in 2019, and within 6 years' time, we have been able. It has evolved now into a critical program here in the Department of Health. So while we are implementing this PMAM strategy around 2015, in a few years' time, no, 3 years' time, we actually passed a law which is called Kalusugan ng at Nutrition ng Magnanay Act. So if I translate it to English, it just means health and nutrition of the mother and baby diet, no? Or basically the first 1,000 Days Act. It was signed in 2018, and it really emphasizes the need for the country to invest in these interventions, particularly specifically includes SAM, so addressing acute malnutrition. And then a year after, or a few months after, we actually signed the Universal Healthcare Law, which talks about making interventions more comprehensive for all Filipinos, and particularly prioritizing those who cannot afford these services, but still very much highlighting the role of whole of system, whole of government, and whole of society approach. So in the background of our PMAM strategy, we had to also reshape it further because of these two legislations that were passed in sequence. So we thought that these were actually quite enabling, no, of the original public health strategy that we had. So in terms of the high-level commitments for the country, we did have the following. So reducing the prevalence of low birth rate to around 10.2% from a baseline of 14.5%, increasing the rate of exclusive breastfeeding to 86.9% from 57.9%, increasing the coverage of treatment services by 50% for children with wasting from a very, very low 9.2% and 4.4% respectively for inpatient and outpatient. And finally, to improve child health by achieving UHC, including access to quality essential healthcare services for 100% of the population. So this is currently standing at 49%. And you can look at this as sort of your metric for good primary care, good primary care access. In terms of our SDG targets, so as mentioned, we do have target of around 3% or 3.7%, which for now we are at a baseline of around 6%, no, thereabouts. In terms also of annual cost, it has been estimated that we will actually need around $535 million in order to address, no, or make sure that we are on track with our commitments. So in terms of the target population, you will see here that the biggest targets will actually really be in terms of improving child health and improving detection and treatment of wasting. So the total number of people that we have already been able to reach are around 363. Yeah. So what are the country actions that we have been able to do in the past few years? So the government has allocated $535 million to implement the priority actions specified in our GAP country roadmap, which includes the following. So first is to strengthen and scale up the implementation of the first 1,000 days law by the local government units. And this is because in the Philippine context, our health system is devolved. So the national government is really more of a policy and strategy, standards setting agency, but most of the interventions, even the health facilities, are owned by the local government units, as well as complemented by the private sector. So this would include provision of in-service adolescent health so that we will be able to target pregnancy outcomes, exclusive breastfeeding rates, rates of children receiving the minimum acceptable diet, and to reduce the prevalence of low birth weight. We will also, through this, increase coverage for healthcare providers at all levels for the management of moderate and severe acute malnutrition and inpatient and outpatient therapeutic care. We are procuring and delivering commodities such as F75, F100, RUTF, and RUSF for management of moderate and acute malnutrition. We try to improve the quality of care of SAM and MAM through monitoring and supportive supervision and conduct of bottleneck analysis. So this is in line or in cooperation with the different local government units and the local health authorities. And also pursue the development of PhilHealth benefit package, and PhilHealth is our national insurer. No? So they are in the process of developing a benefit package so that this becomes the services for MAM and SAM become reimbursable, not just for public facilities, but also for private facilities. And this is our pathway towards sustainability. We have also been integrating the wasting prevention and other essential health and nutrition services in our integrated package of health services across the life stage under UHC. So this is a process that is ongoing. And basically what this means is that we're trying to move away from a vertical model of programming and towards strengthening a strong base of primary care services. So in order to achieve the high-level commitments, the government is also currently in the talks to finalize the implementation of the Philippine Multisectoral Nutrition Project, which is a loan with the World Bank with a proposed budget of $253 million. So there is a component that the DOH health authorities will be implementing. And this is to scale up nutrition-specific interventions. While another component is going to be implemented by our Department of Social Welfare and Development, for which the goal is to foster or to push for more convergence of nutrition-sensitive food, social protection, WASH, and early childcare activities. And then finally, of course, there's the project management part, including data and monitoring and evaluation. So in summary, the loan that we are trying to finalize will actually be strengthening 4 main areas in the local health system. So first would be health promotion. Second would be primary care facilities or primary care provision or the service delivery part. And then the third will be the health information systems. And overall, the fourth is really what governs all of these. No? So being able to capacitate the local chief executives and the heads of the local health authorities to be able to steward the local health system in order to be able to address issues such as malnutrition. On the, again, at the national level, so we are also very, very aggressive in terms of our health promotion shift. No? So moving away from the typical health promotion initiative of printing IEC materials, really working towards not just enabling individual behavior, but enabling and making sure that environments are enabling. So that would include our daycare centers, our communities, our schools. No? And that's really where we will try to make sure that people, young people, as well as their guardians or parents, are really able to be enabled to do and decide for what is more helpful. So among our priority areas in health promotion in the country would include the following, but the malnutrition component really sits within the first priority area of diet and physical activity. So, for example, these are some of the things that we are doing in the country in terms of priority area 1 on diet and physical activity. We have tried to do our playbooks, which is really a one-stop guide for our local government units in order to implement specific health promotion programs. So in this case, no, the health promotion playbook talks about carinderia, or really a small food establishment in the communities. No, these are like mom and pop stores that sell food within the community. And how do we make them helpful? So, for example, some of the things that are really in the playbook would include guidelines, budgeting practices, or even a task list, no, for how they can actually transform their local eateries into these healthy carinderias. And within the playbooks are already some of the materials that they can already use in order to support the local community. So it's really like a template or a toolkit of things that they can do from start to finish. So what are the Philippines country asked? No, to achieve many of our high level commitments, additional budget will actually continue to be needed despite what we have presented, the investments that the country has, and the forthcoming loan. No? And this will be needed from various partners in order to supplement the needed resources that will be required for the Philippine GAP roadmap. Technical support on a more progressive and more aggressive social and behavior change and communication strategy, as well as technical trainings and policy guideline development will continue to be needed. On the other hand, support on supply chain management has already been coming in from various partners, and that's really largely to enable a good local market within the local government units, because when they have the resources, they should be able to buy it from the local market. So for example, now, because the RUTF and RUSF are unavailable throughout the country, the national government is going to be the responsible agency that buys it from the international market, for example, through UNICEF procurement. And we have to distribute it all over the country. Over the years, the idea is for our provinces and cities to be able to self-sustain. And that would mean that if the money will be transferred to them, they should be able to buy it for themselves. Then there will be continuous opportunities for learning such as this that we will need in order to enhance and sharpen our local strategies as well. So with that, thank you very much for your kind attention. And we do hope to learn more from everyone for a healthier Philippines. Thank you.
Thank you, Dr. Hope. Much appreciated. And thanks everybody for your very insightful questions. We'll get to those in a minute. I'll be handing over to Marie to walk us through the Q&A. Unfortunately, I believe our other panelists have been facing some challenges and won't be able to join us. But before we move on to some of the questions, I was wondering if I can start by asking for a couple of additional reflections. Dr. Ahmed, in particular, looking at the Pakistan experience, what would you say is getting in the way of seeing a decrease in the rates of child wasting and seeing that increase that you mentioned at the beginning? What do you think are some of the factors that are driving that, and how do you think the plans and the priorities that you described in your presentation, how do you think that those interventions are going to be able to address some of those drivers to then reduce that prevalence in the years to come?
Thank you, Saul. The issue is that the increase in the number is partially due to food insecurity, which has increased in Pakistan during the past few years. And there are multiple reasons for that, and partially due to the non-coverage of the existing or the inability to treat the existing load of wasting in the country. So we had a sort of piling up of wasting cases for the last 5 to 10 years. Very recently, under the leadership of the Prime Minister, the National Health Task Force that was established 2 years ago, they directed the Ministry of Health to prepare a comprehensive plan to address malnutrition among not only the PLWs and children, but also the adolescent girls. And we have incorporated, or we have made this wasting management as an integral part of that plan. Initially, we would be covering 30% of the country's population, which is around 70 million. But the case load for the country for wasting would be almost 35 to 40%, because we have selected high burden districts for wasting and stunting. So this is, I think, the highest coverage that we would be having in history of Pakistan, because I mean, till recently, it has not gone up from 10, I mean, below 5% to 10% only, with the increase in resources by the provincial governments. So with this resource allocation, and then coupling it with the provincial resources, and plus some of the partners who are working in different humanitarian contexts, we think that we would be able to reach the 50% of caseload of the entire country, at least in the next 3 to 4 years.
Thank you, Dr. Ahmed. In the case of the Philippines, Dr. Ho, I was wondering if you could tell us, I guess, two sides of the same question, which is the legislation, right, that you were describing, the laws that have been passed that really create the space to tackle wasting with the sort of the right legal framework around it. How did we, in the experience of the Philippines, what was the process that led to nutrition being prioritized at a legal level in that way, and what difference has it made to have that legislation in terms of what you can do to tackle wasting? So the experience, we'll be interested, I think, in knowing the experience of how you brought that legislation forward, but also what it has enabled you to do now that it has been signed.
Thank you very much. I do think that we have a very strong CSO based, or civil society organization based, in the country that has been working on this area. And as mentioned, before we even reached that stage of 2018 with the law, there was almost like a decade, no, 9 years of solid work, with actual faces of children and numbers that have been helped, no, by the interventions set out by the development partners when they did some work in Mindanao. I think that was a very, very important aspect. So we weren't selling first 1,000 days or the SAM and MAM interventions like it was coming from the air, right? Or from just, a guideline that WHO or UNICEF has given us, but there was really a solid local evidence, no? I think it was also important to say that one of the pilot areas for the SAM project in the past was Davao, no? And Davao was the home base of our president, no, during this time. And then finally, I think it was also good that while we had CSOs, we did have, members of the medical community who were active in the CSOs. So it wasn't so much really just an advocacy, but the medical part of the advocacy was so strong in that. So I think with that, it was sort of like easy. And then, when you talk about a law like first 1,000 days, who actually should say no to it, right? I mean, it's very, very political sense to say no to such a law like that. So I think if you want to ask us where the challenge is, the challenge then becomes, of course, the law is there, but whether or not you will be given a budget to implement that law becomes the challenge. And so that's, I think, where we also got, in a way, lucky, because we did have some high-level cabinet officials who look at this, no, as their sort of like project. And that's really why this loan with the bank was pushed. I mean, we were also told because of the repeated advocacy work that's being done by many of the CSOs, the partners, UN agencies, even our economic managers have already started appreciating the humongous effect, no, on our economy of the stunting, in particular, the problem in stunting. And so that actually gave way or opened the doors for us to actually do a loan, no, a project loan specifically for nutrition, which is super unheard of. In the history, I guess, of our country. Now, typically, it's really infrastructure-based loan or policy-based loan, but not really a nutrition-based project loan. So I guess the main lesson there for us is a very, very strong advocacy, but with also a good evidence base that talks about the local experience.
Thank you, Dr. That's very comprehensive and very interesting and all very, I think, common sense. So thank you for sharing that. So on that note, I'm seeing all the traffic of questions coming through. I know that the participants have a number of other questions for both of you. So on that, I would like to hand it over to Marie McGrath from the ENN, who has agreed to very kindly chair this Q&A session. So over to you, Marie.
Thank you, Sol. Delighted to be here. And indeed, I'm already inspired to see the Global Action Plan on Child Wasting being practically applied at country level. And in particular how Dr. Ho and Dr. Ahmed, you've really clearly stated what support government needs, your country asks to deliver on your priority country actions. I'll encourage you all to just get busy in the Q&A box and pop your questions in, and we'll get through as many of them as we can in this session. There are already questions arising. Some of them are like clarifications, and then some of them are more broad. So I'll start off with one which I think came in when we were listening to Dr. Ho. Any tips or lessons learned to ensure integration and implementation of nutrition-sensitive interventions with WASH, with social protection and education, such as an early childhood development sectors?
We haven't completed the formula nor be perfect yet in how we're implementing it. It's a work in progress. But what we are sure of is that our former or the typical strategy, which is a lot of vertical programs and trying to talk to our local government units for each program, like vaccination, etc., dedicate people for each, it doesn't work. And we're just asking them to spread themselves too thinly for actually things that are supposed to be integrated. So from our end now is really developing a lot of tools that integrate most of these things. No? So for one, we've launched our integrated manual of procedure for first 1,000 days quite recently. And that's really meant to make our implementers appreciate that these are not separate things. No? And let's not be overwhelmed with these separate things because they're actually really all together. Second is in terms of governance structure, I must also say that in the Philippines, we do have a Ministry of Health, but we did have a National Nutrition Council, a separate nutrition council, which is more interagency work. And so for many years, there have also been overlaps because of course, the Nutrition Council started from the health sector. And so the bias is also nutrition specific interventions, right? Rather than nutrition sensitive interventions. So now you're really working very closely so that more attention can actually be also put to the nutrition sensitive interventions, which they will lead, and that the nutrition specific intervention will be health sector specific will lead. So from a governance standpoint, role delineation is also going to be very important so that we maximize all the warm bodies and minds that will work on this situation. And then finally, it will really be important to have high-level political support. For many years also, amongst agency to agency discussion, very, very difficult to progress. But in particular for this loan that we are talking about, that tries to bring everyone together, it really has been steered by the highest level of the cabinet. cabinet secretary at the highest level. And basically, if you think about it, there's really no technical input at that end, but really just steering everyone to get to a certain place at a certain time. So I would say that those are really the things that are getting us step by step towards the direction where we want to, but still not perfect.
Thank you, Dr. Ho. That really, really very, very interesting and very practical too. Dr. Ahmed, I'd address the question to you from your perspective in Pakistan. What has your been experience of nutrition sensitive and that integration with other sectors?
Thank you, Mary. Actually, unfortunately, this has been a real challenge in the past also, in spite of the fact that the provincial strategies were developed during the period 2012 to 16, and the national strategy, multi-sectoral nutrition strategy, was formulated in 2018. Unfortunately, things have not moved beyond planning as far as the sensitive sectors are concerned. But we had two good examples. One that we piloted in a few districts, the weekly iron folic acid tablet for adolescent nutrition, and it gave us a very good opportunity to integrate with the education sector. And the response of that sector was tremendous, and we have really successful piloting in a couple of districts, which we are now going to expand in our national nutrition program. Secondly, with the support of European Union, there has been a multi-sectoral programming in few of the districts in Sindh province, and which had also covered food, agriculture, water and sanitation, etc. And there, the response has been positive, but I think it required a lot of funding by EU to get things done from them. And lastly, I think the GAP Global Action Plan for Wasting Management has provided the opportunity again for us to sit together and get commitments from the nutrition sensitive sectors. And they have committed a lot, and some are very practical and logical, though there are some very ambitious also. But we hope that with this GAP planning and then the framework of action that we have developed, uh, in the next few years, we expect a lot of contribution from the nutrition sensitive sectors. Thank you.
Thank you, Dr. Ahmed. And again, a question that again can go to both of you is how interventions aimed to reduce wasting have or perhaps could contribute to the reduction of stunting. And perhaps that could start with you, Dr. Ho.
Well, I wouldn't have the actual numbers now. Maybe we could just send that over to the one asking the question. But I think broadly speaking, what we're trying to do is actually to strengthen primary care services. No? So our ability to really take care of the mother and the baby diet. And so logically speaking, we would say that we are hoping that whatever our interventions for stunting, because they're basic services, considering our baseline is so low, no, at 49% access to services, it should be able to help us also with wasting. You know, just basic being able to measure the babies or measure the kids compared to a baseline of not being able to see them at all. That's the impact that we're trying to see.
Yes. So the shared drivers there are between wasting and stunting you're looking to address. And Dr. Ahmed, from your side, because I understand in Pakistan you have been connecting wasting and stunting programs together in a practical sense too.
Yes, Mary, we recently, in the past couple of years, we have integrated wastage management in all these stunting prevention strategies. And the implementation in the provinces is underway for the last year and a half. And our national nutrition program, which is going to be implemented maybe from January next year, would also have the same strategy. And we will have to see what comes out. But the idea is that most of the preventive measures for wasting are the same as for stunting. I mean, focusing on IYCF, exclusive breastfeeding, and then continued breastfeeding, plus focusing on maternal nutrition. All these are efforts which are directed towards the wasting prevention, and the same would also lead to stunting prevention. Additionally, we have recently focused on adolescent girls also, which again, unfortunately, have a very high burden of anemia in Pakistan, and the same anemia moves on to the WRAs and PLWs, and almost 50% of our WRAs and PLWs have anemia. So we think that if we break the cycle of maternal malnutrition and healthy infants, we will be able to break both. Plus, then the early detection and management of wasting would further prevent the children going into the chronic malnutrition and stunting.
Thank you, Dr. Ahmed. So we've got a few more questions in. We've got a few sort of practical or sort of clarification information questions for you, Dr. Ho. So I hope you bear with me while I give you a few question and answers, which I'm sure you'll be able to answer quickly, or you'll find out the information if we need. One of them is a practical question around, do you have any problem putting the IMAM treatment or the wasting treatment on the insurance scheme in the Philippines, since RUTF is not on the list of essential medicines?
Yes, always. And plus also part of the UHC law is to institutionalize the health technology assessment process. No? So it's like now like there's really more barrier into what the national insurer can pay for. But then this is really also where the law is important, right? Because there was a specific law that talks about these services should be provided to the people. So yes, but I think we've gone beyond that stage because we're already at the costing stage with the national insurer. And for sure, I think now the sort of like the saving grace is we're able to buy it from the national government side. No? So if any, like in our other benefit packages for the national insurer, like for TB, some of the drugs are still paid for by the national government, and the service fee is actually paid for by the insurer. So there's still quite several models that we are looking at. So worst case scenario, the national government will pay for the goods, and then the service fee will at least be covered by the insurer.
Right, that's really helpful. And Dr. Ho, again, there was a quick question. What type of RUTF for wasting is used in the Philippines?
We buy both RUTF and RUSF in the Philippines, both from UNICEF.
Both from UNICEF, great. And again, another question, sorry, this is like a little list. What are the measures that are in place to support enforcement of the law of the act in the Philippines?
Usually, for every law, they will have an oversight committee headed by some members of the Senate and some members of the Congress, or the representatives and the senators. So both houses, they will form a committee, and every year they will get us into submit a report, and then if there will be needed, a public hearing to say which parts of the law has been implemented or not. And apart from that, every year we actually submit our budget requirement, and in that process, the various legislators are able to ask us, is this done, etc., etc. I think that's really the most formal way for them to ask of accountability in terms of implementation.
Okay, thank you. I'll give you a little breather now, Dr. Ho, and I'll come to Dr. Ahmed. And this was a question, like, how do you adapt? Like, have you adapted your related services during the COVID-19 pandemic? It's quite a topical question.
In the very first few months, when there was a complete lockdown last year, I think it was from during April to June, we had some issues. I mean, of course, due to complete lockdown, there were restrictions on the movement, and there were some disruptions of services. But these services were still available in the big treatment centers, the secondary and tertiary care hospitals, in spite of that. And there were some issues also that nutrition centers were transformed or converted into the isolation sites for COVID patients. But this was only initially for 3 to 4 months, maximum 5. And we discussed this issue with the national, NCOC, which is the highest body taking care of COVID emergency in Pakistan, and we discussed with them, and with the support of the Disaster Management Authority in Pakistan and the district health system, we made sure that the nutrition centers not only remain open, but they are functional. And we immediately prepared the guidelines for healthcare providers dealing in those centers, as well as the uh, receiving end of mothers and children, how they can be managed and treated. And this worked really well. We had support of all the partners, nutrition, UNICEF, WFP, WHO, who were managing these sites according to their mandate. I mean, the OTPs, the TSFPs, and the stabilization centers. And it really went well. And for the last more than a year, we do not have any interruption in these services.
Great, thank you, Dr. Hamid. Dr. Ho, what challenges has COVID placed on your services in the Philippines?
There were very clear studies that showed, because we also had very long lockdowns and restrictions. So clearly, and maybe if you call it an effective risk communication to a certain extent, people really got scared, no? And that actually meant also that the mothers weren't able to bring their kids to our health centers or local health centers. And so the challenge was for many basic services for young children. There was a drop, no, around 40 to 60% in terms of service provision. And this was also reflected in the statistics in terms of health insurance reimbursements. So both reflected as very, very huge drops. That would then mean that the adaptive mechanisms will entail trying to have the mothers be able to do some of the interventions at home. So for example, for wasting, I think we just adopted a simplified approach of asking them to use the MOAC tapes to measure their kids, instead of doing weight for height, which will be a little bit more complicated. And so we also provided the supplements for them in more, instead of like giving them sequentially when they go visit, so that they just have it at home with them. Then for vaccination, for example, which is also related, we had to do a lot of catch up outreach activities. So it's really bringing the services closer to them because they really cannot or would not travel to the health centers.
Thank you, Dr. Ho. And the questions are coming in thick and fast now. I think another one for you, Dr. Ho. What are the lessons learned on improving the overall SAM, or I guess wasting data in your country? Is there any strategy on data quality improvement from the implementation side that you could share with us? Any practical tips on improving data quality?
I think we're just in a way fortunate that there's a specific public institute that does the National Nutrition Survey every 5 years, and in between the 3 years they do have a smaller survey. So we rely heavily on that. But if you talk about service coverage data, we are also, like many other developing countries, continue to struggle with it. But we are restraining ourselves from wanting to build some specific or malnutrition specific data system or information system. So actually, in fact, as part of the investments that will be coming from the loan, what we will be making sure of is that we are going to support like EMR-based systems in health facilities, because that will have, you know, cross-cutting effects. Various programs will be able to use it, and then we will be able to Also not overburden the providers for every single report that we will have. No. So as it is now, we have almost 30 parallel information systems that we're asking them to fill up. So I guess I would really just say that this is still a very big problem from our end, service coverage data. Currently, we're getting it 3 months to 6 months delay, from various health centers in the country, and not able to get regularly from private providers. So that's a big gap. So moving ahead, the goal is to really roll out or provide support or subsidy for them to have electronic systems that are disaggregatable. No? So meaning they're not submitting to us like in totals that we cannot actually verify.
Yes. Dr. Hamid, and I know you again as well are probably facing maybe similar or different issues in Pakistan. What are your experiences around data quality, the challenges, and also perhaps some of the lessons you've learned, and indeed any of the asks that you might have to really try and support your efforts to improve data quality?
Yes, actually, we really had a lot of issues, and I mean, you rightly pointed out, getting data, especially about the nutrition programming, was really a challenge because it was being implemented in the country in bits and pieces. Somewhere there were humanitarian interventions going on. In other areas, there were some provinces working in some of their own districts, while then UNICEF, WHO, and WFP, based upon their resources, they were supporting the provincial governments in some of the high burden and high risk districts. And we received different information from different areas. And then, as I mentioned earlier, that European Union was implementing a project, a pretty huge project in one of our province. Very recently, we have tried our best. I mean, we have used this COVID emergency as a sort of enabler, and we have tried to streamline the information. We have developed specific indicators for nutrition programming, which we usually update on bi-weekly or monthly basis. National management information system on nutrition is under development with the support of UNICEF, and we are also updating DHIS2 in Pakistan, and it also includes nutrition indicators. But definitely we are because getting information and then streamlining it and then compiling it and using the analysis for decision making is a very uphill task for especially a country, a huge country like ours, where multiple programming and projects make it difficult to harmonize data at times. As I mentioned, I mean, if we get some support in developing the monitoring framework and dashboards at the provincial and national level, that would be a great help to us. But we are trying our best, and even if we do not get support, we will try to manage it, but that it will take a bit of time, and the support can speed up the process.
Thank you, Dr. Hamid. And I will keep you on the line because there's another question that I think you'd be well placed to address. Very interesting one, raising the point about pregnant and lactating women also can become severely malnourished, and it may not necessarily lead to immediate cause of death, but it can be a leading cause of low birth weight, a contributor to low birth weight, and indeed child wasting and stunting and poor outcomes in these children. And so do you have any reflections or thoughts on that and how that's reflected in the priorities for Pakistan?
This is very important questions, and I mean, the person who has written this question is, I mean, I must congratulate him that he has raised this point. In the last couple of years, we have a specific desert area which usually is prone to different emergencies, especially droughts, and there were a lot of child deaths. But it was found out that these were early infancy deaths, much before the time they start complementary food, and it went back to the mothers, PLWs, which are highly severely malnourished, and this really not only ring a bell at the national level but at the provincial level also. So since then, as I mentioned, we have focused our attention on PLWs as well as adolescent girl. I mean, for anemia prevention, we program has interventions from PLWs, and then we have made an integral part of this nutrition programming that every woman coming for antenatal care, apart from other routine examinations and supplementation, she would be screened for malnutrition. And if malnutrition, she would be provided this supplementary nutritious food till the time she is malnourished. So we do realize it, and we have included this in our programming. And we really acknowledge this fact that one of the main reasons of low birth weight, which later on can lead to stunting and wasting both, is the maternal malnutrition. And we are focusing on that. Very recently, we have developed our maternal nutrition strategy, and all these issues regarding the PLW malnutrition has been addressed in that strategy. Thank you. We really like to thank the support of UNICEF and other partners, WHO, UNICEF, etc., in sort of highlighting these issues in the country and making the government take necessary steps. And I think we are moving in the right direction now.
Thank you, Dr. Ahmed. And I guess a related question has just kind of come in. If I could just take a few more moments of your time, and then I will address the same questions to Dr. Ho, is that Amanda, I think from Uganda, has said whether you've any experience in identification and treatment of wasting in infants under 6 months and their mothers. So I guess we're all acting to try and prevent low birth weight, but those cases are still happening, and those babies may be born wasted and stunted. So is it a problem in your country? She wants to know.
Yes, it is. And specifically one of our province, Balochistan, which is really far-flung and mountainous as well as desert area, we face these problems. And we know that one of the main reasons is maternal undernutrition, but we have to manage it. And these children not only come with the undernutrition or wasting, they have also other complications with that. So most of these cases are taken care of in our stabilization centers and that are developed there. But if there are cases which have only wasting, and we have to manage it. And definitely we cannot leave any child behind. And this is the, I think, slogan: leave no child behind.
Thank you, Dr. Ahmed. And Dr. Ho, from you, just again, just the area of sort of maternal nutrition and health, low birth weight, and then any problems you have with infants under 6 months in your context.
In our case, our main intervention in this area is really helping mothers do optimal breastfeeding. And that's really through a lot of activation of a lot of support groups, which are, I guess, outside the formal healthcare system. So being able to activate them and working with them so that the mothers are actually supported. And then, of course, as what Dr. Ahmed has also mentioned, it ties back to maternal undernutrition. And so with increasing cases also of teenage pregnancy in the country, so that very much ties with it. So our campaign for adolescent sexual reproductive health is going to be critical so that we don't get to actually this stage.
It's back to integration and the interconnection between all these systems and services. And we often talk about health as being one sort of homogenous group, but it's all the dimensions of health within that. And maybe I could keep you on, Dr. Ho, and start this question with you. A really interesting question as well. Could you share your experience on coordination of interventions at central level or national level, and how it's decentralized at local levels, like local administrative entities and communities?
Yes, thank you. This is, I think, a perennial challenge for everyone. I would just say that within the central level, at least for us in the Ministry of Health, within our bureau or office, we have a nutrition focal, a maternal focal, a child health focal. And actually, it has been already a challenge to bring everyone together because we're used to being so specialized, and everyone drafting their own policies. But there is a very, very strong effort now to do integration work, and that means our policies, forward-looking policies, are going to be client-based, meaning we integrate our policies based on who the beneficiary will be. So in this case, if it's an under 5 infant, or then we integrate at the policy level. And then the Ministry of Health here in the Philippines, we do have our regional offices, and that means they're in charge of overseeing several provinces. Beyond the regions, we actually don't have any more personnel. That's well within the ambit of local government units. So at the regional level, we are still able to work with other national government agencies to do coordinated planning. But at the implementation level, that's really where it's fully devolved, no? And our main participation then will really just be to provide either technical assistance in the form of money, grants, feedback, like giving them scorecards, providing training, or even just giving them commodities that we purchase, no? But that's really basically the main interaction. But the local government units have full reign of what they want to be able to do, and they just consult us really when they need it, or if it's part of the priority provinces, really the geographically isolated, those with really poor outcomes, then the national government really sets aside a team to help them out.
Thank you, Dr. Ho. And maybe over to you then, Dr. Ahmed. I'm sure we'll be soon wrapping up our questions and answers, unfortunately, but really your experiences of decentralization.
There was a constitutional amendment in Pakistan in 2011, and health was decentralized to the provinces. Before that, health was the central subject. So now at federal level, we do develop policies, strategies, and guidelines, and legislations, and standards, etc. But actual implementation lies with the provinces, except the regions which I mentioned earlier, Gilgit-Baltistan and AJK, another area, Islamabad Capital Territory. I feel that provinces initially lacked a lot of capacities of implementation and monitoring and evaluation. But later on, they have gradually developed all these things. The issue is still with the resources at the provincial level. I mean, coordination and collaboration is perfect, and it is trickling down from federal level. We do have a lot of a couple of platforms which are multi-sectoral, and similar platforms have trickled down to the provinces and even locally at the very district level. But the issue is mainly resources, and that is why federal government has decided to support the provinces in implementation of nutrition programs with a main focus on stunting prevention and wasting management.
Thank you, Dr. Ahmed. Well, I think our questions and answers time is drawn to a close. And thank you so much for being so accommodating and on the ball with your questions too. I'm so impressed. And I'll hand over now back to Sol.
Thank you, Marie, and thank you, Dr. Hunt and Dr. Ahmed, for your great answers to great questions. Thanks as well to everybody who has been taking part and sharing both your insights and your questions with us. We appreciate it. As we bring this webinar to a close, I want to hand it over to Zita for some final reflections from today's conversations. But before I do, I just wanted to thank our speakers, Dr. Ahmed and Dr. Ho, for not only for the time that went into preparing today's presentations, but also for taking the time and the effort today to paint a picture of what the experience in your countries has been in prioritizing child wasting and taking all the different decisions at all different levels to launch a coordinated response to this challenge. So on that note, then Zita, over to you for some final words before we wrap it up.
Thank you, Sol, and thank you to the speakers and the discussion, which was extremely interesting. I have a few key concluding remarks that I pulled together and summarized in 5 points. The first one is timely detection and treatment of wasting needs to be an important and integral part of the overall nutrition agenda on improving nutrition, including all forms of malnutrition through a multi-systemic approach contributing to the SDG goals. So that's sort of an overarching point. The second one is the timely detection or early identification and access to quality treatment of wasting must be part of a continuum of care, from treatment to sustained recovery and to prevention, in order to reduce the numbers of children needing treatment and improve access for treatment to reduce mortality and negative short and long-term health consequences. The interventions on the early identification and treatment of wasting need to be evidence-informed. Just as information, WHO is currently updating and developing recommendations on wasting, where gaps still exist in recommendations, and also updating existing recommendations based on the review of current new evidence. Some examples of the topics that are going to be covered in this WHO guideline development, without going into detail, is reviewing the risk profiles of wasted children and determining who are at higher risk of deterioration and mortality and need immediate care, updating recommendations on the overall treatment and prevention of wasting, including infants, but also for children, and looking at modalities of care at all levels of the health system, especially at the community level, which includes community health volunteers and community health workers, and what can be expected from them in different contexts. WHO partners are also developing operational guidance and tools to support countries in scaling up and accelerating early identification and treatment of wasting. We've heard today both countries said one of the challenges in this area is the high cost of RETF and RESF. And we are looking into ways together with UNICEF and other partners in trying to look at reformulations, look at what evidence is needed to come up with different formulations of RETF and possibly reduce the cost, but also looking at local production, what needs to be in place in countries so that RETF can be produced locally in the local market and procured by the government locally. So this is work that we are doing this year, which will continue into next year. Concerning the prevention of wasting, the important linkages have been mentioned and they are reflected in the gaps. All mentioned it at the beginning. It's the first three outcomes reflected in the Global Action Plan. The first one on reducing the incidence of low birth weight by improving maternal nutrition. So there was also comment about the need not to only focus on children, but also to look at maternal malnutrition and address that. So looking at it more from a life cycle point of view. The second outcome in terms of prevention is improving child health by increasing access to primary health care and the water, sanitation and hygiene services. And the third one that's reflected in the gap is enhancing infant young child feeding, improving breastfeeding practices and children's diets in the first years of life. We've heard from both countries on how they have pull together commitments and have targets on these outcomes as well. Most of these topics will be discussed in more detail in the other sessions this week, linked to the N4G Health Week. The humanitarian context is something that should not be forgotten. In addition to the stable situations where actually most of the burden of wasting is found in terms of numbers. But given the expected increases in wasting linked to the increase in food insecurity, we've heard also from Pakistan, we should not forget the humanitarian side of things, especially in terms of increased the conflict dynamics, the economic shocks, the socioeconomic impacts of COVID, as we've heard, the weather extremes, climate, and so on. In these both examples, humanitarian context was very much the center of some of the discussions. As Philippines, Dr. Ho, as you mentioned, the CMAM program actually started from the humanitarian side and went into the broader health sector intervention later on. And Pakistan is still affected, many territories are affected by humanitarian issues, even currently, that need to be addressed maybe in a slightly different action-oriented manner. That was a long second point. The third one is that investments made into developing country commitments on the prevention and treatment of child wasting is now being recognized by countries as an important way forward to improve nutrition, specifically on the reduction and treatment of wasting. We've seen it in two examples today, Pakistan and Philippines. They've highlighted the key priorities and actions, the commitments, the targets, the key priorities and actions to deliver essential interventions in healthcare and to ensure the reduction and prevention of wasting, including capacity building, need for therapeutic products, the health nutrition surveillance, the screening for early detection and identification, and as I mentioned, really looking at it more from a high life cycle approach. The two countries have also highlighted challenges and way forward, including the financial considerations. And we've heard how they have managed to get government commitment in terms of budget, both Philippines and Pakistan, but also loans and other support. That was my third point. My fourth point is there is a huge opportunity at the country level, not only regarding the development of ambitious and impactful commitments that we've heard about from the two countries, but it's also about the integration of these of actions into health systems and linking to treatment and sustained recovery of wasting, and linking treatment and sustained recovery of wasting to healthy diets and to ensure health for all. So again, it's the prevention side. But the opportunity is not only in terms of developing the commitments, but also in terms of strengthening partnerships and engaging key stakeholders to support governments in the implementation and monitoring of action plans based on the commitments as well, the need for identification of possibly innovative funding mechanisms to be able to support all of this. My last point is the call for commitments is not only for the 23 frontrunner countries of the GAP roadmap process, but for any country that is planning key priorities and actions for the reduction and treatment of wasting. We have seen two countries' best practice examples that will hopefully inspire other countries, in addition to the frontrunner GAP countries, to make commitments to reduce wasting and decrease mortality and improve the well-being, especially of mothers and their children. Thank you. Back to you, Sol.
Thank you very much, Zita. What a wonderful note to close today's webinar. Once again, thank you, Dr. Ho, and thank you, Dr. Ahmed, for taking the time today to walk us through the experiences from Pakistan and the Philippines. We are in debt to both of you for enriching this conversation. We remain also at your service to support you in doing this incredible and ambitious agenda that you have to address wasting in your countries. Thanks also to everyone who has taken part in today's webinar, including everybody who put your questions and your comments forward. Thank you to Marie for agreeing to jump in and helping us facilitate the Q&A. Much appreciated. Zita, Tram, and Jorgen, thank you for organizing and preparing so much of today. And of course, to all of our interpreters who have been translating for many of our colleagues around the world, thank you, everybody, for making today's event so accessible and so rich. On that note, I will say goodbye to all of you and encourage you to join the next session taking place, I believe, in about half an hour on the promotion of breastfeeding. Until that time, thanks again for your time and attention, and look forward to continue to work together on the prevention, detection, and treatment of child wasting around the world. Thanks, everybody.
Thank you very much. Goodbye.